We're going to inaugurate our, thank you. We are now recording, inaugurate our brand new introductory slides to be fully compliant with the open meetings regulations for the state, where we've decided to formalize a little bit. And so as I always ask you to be a little bit, bear with me as I read through this, but it's important so that we follow the rules and everybody feels that this is a fair representation of what our public fiduciary responsibilities are. So we're going to always start the meetings, as we've talked about, with a restatement of our purpose, which is our legislative charter, which is to review the available research literature and assist the Department of Health, which I'm not sure in the course of after this next reorganization if we will change the name of that, but we'll see how that goes. It'll probably be a name change. And Center for Medical Cannabis, in their efforts to provide useful treatment recommendations to qualified medical providers regarding, and I'm going to sort of edit as I go here because there's a lot of shifting sands, and Rich is going to talk about some of those, as maybe Dr. Woolsey will, with regards to the legislative session and changes within the Department of Health and Human Services, et cetera, but also with limited medical providers, we may need to modify that as well. Although I'm not sure how we do that with the way the law is written, but we'll get advice from counsel on that. So currently to qualified medical providers, but I would caveat and limited medical providers, regarding the use of cannabis and cannabinoid products for treatment of certain medical conditions identified as qualifying medical conditions. So next slide, please.
Just a second here as there we go.
So with that stated, my name is Perry Fine. I'm currently the chair of the Cannabinoid Product Board, into closing on the end of my second year in term in this position. And this meeting is being held virtually and hosted by the Department of Health and the Center of Medical Cannabis based in Salt Lake City. Public notice of this meeting was provided as required under Utah's open meeting laws, and it was posted on the Utah Public Notice website. In compliance with Utah's open meetings law, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. Written minutes will be prepared of this meeting, and approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board approval. Next slide, please. The current board consists of 7 members, 6 other than myself, with Drs. Lauren Heath, Brian Zender, Catherine Carlson, Misty Smith, Jennifer Norris, and Dr. Matt McGiff. And we see Drs. Norris, Drs. McGiff, Dr. Smith, Dr. Carlson, and Dr. Heath with us. So we fully certainly do have a quorum. Our staff attendance is usually in attendance and are here today. That's Dr. Woolsey, Director of the Department's Division of Family and Health Preparedness. And I want to pause here for a moment to say that I believe, and correct me if I'm wrong, Dr. Woolsey, this is your last meeting with us. Dr. Woolsey has just been an extraordinary leader over the last year, diving in both legs, both arms, head, and all extremities, every body part, abdomen, thorax, in order to help us move our agenda forward. That is our charter, and has really taken the bit in her teeth. And she's moving on. You can maybe do a quick statement when you're up for your discussion, Dr. Woolsey. But going back to what I understand is your true love, and that is working with community health centers, dealing with population and individual health in a more direct and clinical way. So we wish you Godspeed and just unbounded appreciation for everything you've done to support us over this last year. And I know you'll be sort of watching from the sidelines. Dr. Michelle Hoffman, medical director for the department, will be taking over, and we've had a very constructive meeting already, so we have a smooth transition it's a steep learning curve, but Dr. Hoffman, I know, is up to the task. And then, of course, we have Rich Oborn, who's our CMC director, Melanie Shepard and Sarah Ponce, who provide invaluable administrative assistance and help and keep us functioning. Next slide, please. So I think it's always good for everybody who's on these meetings to know who's really doing the work behind all this. So we do welcome all visitors to our virtual meeting at this time. We are still meeting and plan on continuing meeting virtually until we really get the all clear and we feel that we can move forward safely, and we'll sort of determine and keep people posted about that. If you're logged into this meeting with a phone number and not a name, please type your name in as a comment or state your name now so we can add your name to the meeting minutes. So Melanie can record that. A public comment period will occur at the conclusion of the scheduled agenda. Select the raise your hand function appearing at the bottom right of the screen, and we'll do our best to accommodate a request to make a comment, which will be limited to 2 minutes. I think we've got a little bit of a typo there, so we'll correct that. Yes, comments will be limited to 2 minutes. We need you to state your name, affiliation, and disclosures related to financial interests pursuant to the agenda item you would like to address. So anyway, a little redundancy there, we'll fix that. As a courtesy to everyone participating in this meeting at this time, we request that you place yourself on mute unless you're speaking to the group, and board motions and votes will be recorded in the minutes. All right, all of that said, we can actually move on now 7 minutes into it with our agenda, which starts with an approval of the minutes. This last meeting in February was a lengthy one. We took every moment. We had a lot of commentary from those who attended. It was a very interesting dialogue and discussion back and forth, and we arrived at certainly, I think, a very important conclusion with regards to THC analogs, et cetera. But the detail of that, I think, has been well captured, as well as other aspects of the meeting by Melanie, and I do not have any corrections or comments myself. Does anybody else on the board or administration have anything to add to the board meeting minutes that were sent out prior to this scheduled meeting? Hearing none, may I hear a motion to?
I make a motion to approve the minutes.
Dr. Zender makes a motion to approve. Is there a second?
I second.
Dr. Smith makes a second. All in favor with a show of hands. Aye is a show of raised hand on the video. Can you capture those, Melanie?
Yes. One other thing, our chat is off for this meeting. So could WB jump on and identify yourself? And then there's a phone number so I can put your names in.
Melanie, this is Mark Babbitts. I'm the phone number 801-558-7944. My computer has no camera, so I use the computer to look at the slides, but I have to call in to listen and talk.
Okay, thank you so much.
Hey, Melanie, WB's Wendy Brager.
Thank you.
You bet.
And welcome, Dr. Babbitts. It's good to hear your voice. All right, moving on with the agenda. I'm going to turn the microphone, if you will, over to Rich Oborn. It's been a really active legislative session with regards to all things cannabinoid. And there's been a lot of filtering necessary to figure out where things are and what's finally going to end up on the governor's desk. But I'm going to leave that to Rich with any additional comments, perhaps by Dr. Woolsey, to supplement going forward. So Rich, why don't you take over from here?
Great, thanks. Dr. Fine, can everybody see this first slide? Wonderful. Great,
Rich,
so we're just gonna do go ahead.
Rich, I'm just seeing can you, are you able to put that under?
Let's try this. There we
yeah,
go. Sorry.
presenter?
Okay. Is that better, Dr. Fine?
It's still pretty small. Is there
Can you put it under present mode, Rich?
what I was?
Yeah, go ahead and
That's
presenter
what
mode,
let's
slideshow.
see. Just a second here as I play with this. Sorry. Hey, come on.
Rich, down at the bottom right, there's where it says notes, and then the farthest little screen with the stand, if you hit that, that should go into presenter for you. Down bottom corner right.
I'm afraid my screen looks different than yours. Sorry.
Okay. Why don't you go ahead, Rich?
Yeah.
I'm
Sorry
It's
about
When you
that.
go into presentation mode, you have to pull the presentation back over to the monitor that's being displayed. It extends it to a different monitor.
Oh, okay. I'm not as versed in Zoom as I am Google Meet.
You can
So-
also, when you put it presenter mode, you can also share out just the presented side of the slides as well through Zoom.
we've all become way too expert at at Zoom.
Hey, Rich, just shrink your notes and the slide will get bigger, and then you can go ahead. Yeah, there you go.
Is that
There
better?
we go. Yeah,
All
now
right.
it's readable. Thank you, Rich.
Okay, sorry about that. Great. Okay, so a little disclaimer. I just want to emphasize as we go through this, that this is some highlights of the medical cannabis legislation that passed during the 2022 general legislative session. And my intent is to provide information that's current as of the date of this presentation, obviously, but while this presentation outlines some medical cannabis legislation passed during the session, it's not intended to be comprehensive. That there are some bills that indirectly impact our program, and we won't be covering everything. Also, while Governor Cox has not yet signed the bills discussed there during this presentation, it's likely that he will sign them, but you never know. He still has the authority to veto. And last year there was a hemp related bill that he did veto. So anyway, I share this information with that background as well. And then complete copies of the bills discussed during this presentation and the entire Utah Medical Cannabis Act and other laws relating to medical cannabis in Utah are all available on the Utah Legislature's website at le.utah.gov. So you can go there to learn more about the bills. And then I want to emphasize also that the presentation is for general information purposes. It's not intended to be and should not be used as legal advice. Okay, great. We've got that disclaimer out of the way. So at a high level, we've got 5 bills that directly impacted the medical cannabis program in Utah. Some of these impacted Utah Department of Health directly, and others impacted the Utah Department of Agriculture and Food a little more directly, but we're still indirectly impacted. So the first one was Senate Bill 195. We have Senate Bill 190, Senate Bill 153, Senate Bill 46, and House Bill 2. All had some impact. So we're going to go into a lot more detail on each one of those as I present. All right, so Senate Bill 195, this is the Medical Cannabis Amendments Bill. And this was sponsored by Senator Escamilla, and the floor sponsor was Representative Ward. And the first item is the Cannabinoid Product Board name change. So the name of this board that we're meeting with right now is changing from the Cannabinoid Product Board to the Cannabis Research Review Board. Also, QMPs at hospice programs. So a hospice program must have at least one QMP registered with the Utah Department of Health as a QMP to recommend medical cannabis for the treatment of hospice patients. So there's hospice programs throughout Utah, and they're all required to have at least one QMP. Also, all 4 physicians on the Cannabinoid Product Board must be registered as QMPs by July 1, 2022. And we'll be reaching out to each of the physicians on the board to make arrangements for that soon. Also, acute pain was added as a qualifying condition, and this happened by modifying the definition of pain as a qualifying condition to include pain for an acute condition, including a surgical procedure for which a medical professional may generally prescribe opiates for a limited duration. When acute pain is designated as the qualifying condition, the card will be issued for 30 days, so it'll expire after 30 days. If the patient wants to continue after that, they'd have to qualify under a separate qualifying condition. And so it's for that limited period. This just gives patients, for example, that go through a surgical procedure, it gives them this alternative for medication if they choose to have it and if their provider supports it. Okay, there's quite a few advertising related restrictions that are placed in SB 195, and those related to medical cannabis couriers, a medical cannabis pharmacy, and a medical clinic that offers medical cannabis visits. And for example, a QMP or a clinic that employs a QMP, they have they can advertise, and that was clarified in the law, but there are certain limitations to what they can advertise. So there's a lot of detail related to that. And then medical cannabis pharmacies, they have their own set of advertising restrictions. And then also medical cannabis couriers are similar to medical cannabis pharmacies in the type of restrictions that they're under as far as advertising goes. And the Utah Department of Health was given authority to write some standards in administrative rule that will further define those advertising restrictions. Also, there are restrictions on third parties. So for example, a third party would not be able to be the entity that actually does the advertising for the pharmacy. It can only be the pharmacy that advertises for themselves. They wouldn't be able to go and have all these others advertise medical cannabis products and things. So the advertising ability is limited to those licensed entities. Also, advertising of subsidies to low-income patients is allowed by third parties and by nonprofits or by medical cannabis pharmacies. And so that was clarified in the law that is a type of advertising that third parties can do in order to spread the word about certain subsidies available for low-income patients. Also, item 8 is just medical cannabis pharmacy business name and logo standards. There's some specific terms that are called out that you would not be able to use in the name of a medical cannabis pharmacy. And there are a few terms specifically named that are acceptable to be used in the name of a business that is a medical cannabis pharmacy. So the purpose there is to emphasize a medical disposition opposed to a adult use or recreational disposition of those entities. Item 9 is just recommending medical provider in their consideration of a patient's history of substance use or opiate use disorder. So this is just an emphasis on a best practice of how a provider, as they meet with every patient, they are to consider the recommendation that they're determining whether to do or not in light of the patient's history of substance use or opiate use disorder, which is, I think we can all agree that's something that's really important to screen for. So that is Also, just as an aside, the law also requires that recommending medical providers also check the controlled substance database and consider the history of use of controlled substances in light of the recommendation that they're considering at that time. So also item 10, medical cannabis may be delivered to a medical facility where a cardholder is a resident, such as a hospice facility, care center type situation. And I've put little asterisks near those provisions of this bill that will require some software changes. And so it's not like immediate we'll be able to enforce these laws. It will take some tweaks to our software in order to do that. So we're working with our software vendor on incorporating these into some other changes that we're already planning on doing. Also, item 11 is just that the University of Utah School of Medicine must ensure that physicians who will receive fellowship training to specialize in pain treatment are QMPs. Okay, so that gives you a very high level summary of some of the amendments that were put into place with SB 195, medical cannabis access amendments. Are there any questions about the amendments that came in SB 195?
I have a question about number 9, about recommending the provider have consideration of the history of substance use. Is that to be recorded in the chart at every visit, every renewal, or is there more specific detail about that?
So the language in the law, it literally states that the recommending provider is to consider the recommending of the card in light of the patient's history of substance use or opiate use disorder. So it doesn't have, the statute doesn't have specific details, but I think one can conclude that that would certainly be a best practice, that it would be recorded there. There's some conversations I think we're going to have with other sister agencies like DOPL regarding this, because if there were an allegation of a provider not doing that, it would be DOPL that would be able to have the ability to subpoena the records that would actually provide evidence of a failure or a having done that or not. As you know, as a provider, it's always good to document, right? In order to protect yourself as you have different requirements in the law. So my expectation is that providers would document that. And if any of the providers on the call have any thoughts, or Dr. Woolsey on that standard, you're welcome to expand on that, but those are some of my thoughts.
Yep, Rich, this is Sarah Woolsey. I think you did catch it. I do think that the program, the center, will continue to put this into every bit of education that we work on. And we have already asked all the CME companies that do any education for us to add this in. So if they hadn't already, for example, University of Utah has an extensive section on that in their qualified medical provider CME. So this is now will be a standard of our training and teaching. But Jennifer, to your point, it is vague. It's vague. So acknowledging that. Yeah.
Also, I think it's similar to the legal requirement that the controlled substance database be checked. Because before any initial recommendation comes, the recommending medical provider by statute is required to check that and to consider any history there as they determine whether a specific patient should be recommended medical cannabis. So,
and Rich, that my question related to that specifically, that is the technology or the kind of pathway in place for DOPL to monitor and, see evidence that the DOPL, that the CSD has been checked by providers who are recommending cannabis, just like any other provider.
Yeah. Yeah, that's something I believe the controlled substance database tracks access anytime people access it. I'll confirm this, but I think
They do for substances that are registered in the CSD. And right
Yeah.
now, as we know, cannabis pharmacy products are not.
right.
And the system for getting, I just tested it out recently with a patient of mine. The system for verifying whether a patient has a card is, it's very separate from the CSD, as we know.
Yeah,
So I'm just
and-
wondering, has that been crosswalked so that
Not yet, but it's in progress with our vendor and with DOPL and the CSD. It'll be crosswalked.
So Katie, that technology is coming in terms of it being more seamless for you to see like you would see any controlled substance, but it's not there yet.
Yeah.
But the second piece you're asking about in terms of mandatory assessment of checking and sort of that thing,
Yes.
there's not yet any statute that requires that. My guess is once the crosswalk's there, it is something that could then be tracked, but that will take additional software programming, as you can imagine. So I
Yeah.
think we got to put that on the list.
That's what, so essentially that number 9,
Mhm.
or that portion of number 9 is not in place until the EVS is integrated fully into the CSD.
Nope, Katie, we would ask that providers do a screen like you would on anyone, either a verbal screening, paper screening, urine screenings, however your practice chooses to do it. So we're going to start to up the ante in terms of that expectation. And then the next piece will be, a formal data tracking, but this does not yet reflect the data portion. But we would expect that people would be doing, best care in terms of their screens for that as they are assessing the patients. So
Okay.
it's starting out general.
Yeah. So, there's always, I understand a difference between a patient self-reporting a substance use disorder or opiate use disorder to their provider, and them actually seeing that there have been drugs prescribed that help treat those conditions in the controlled substance database. And in the future, it'll be a little more streamlined. It'll be quicker to be able to assess those items, but it's still important that they screen and ask questions, and we will expect that they do that under this law.
And
I just wanted to point out that the Compassionate Use Board has a petition form that the QMPs do sign stating that they have reviewed the controlled substance database for each patient. So we do have that in place for people submitting Compassionate Use Board currently.
And I'm just curious, is there any requirement or guideline that providers who are doing these recommends check urine screens
No,
and then do monitoring of urine screens
no,
for tox?
no, it could, I think it depends. It's important that a provider, every situation could be different, right? If they, as a physician, feel the need to, within their responsibility, depending on the type of facility they're in, to as a condition of treatment, require that they do certain things. It may be
Katie?
reasonable in some cases.
Or Dr. Carlson, there's not actually a law that we have to do it for any other substances, but we do have state guidelines that have been developed around opioids. So we have guidelines, but we don't yet have any statute around that for any substance at this time, unless they're in a drug treatment program. Yeah.
Yeah, and that's really what I mean. I mean, for pain management, prescribing, I mean, that's part of the guidelines for managing someone who has conditions with pain, is that you check the urine toxicology regularly.
Right. So that guideline continues. I would hope that every provider when those conditions apply, that they would execute that. Yeah,
In fact, it's a standard. It's a standard of care.
right.
Yeah. Yeah.
A few comments here. Before we leave number 9, it's an interesting piece of legislative language because the word consideration has no meaning whatsoever when you really think about it. It's vague and ambiguous and doesn't hold anybody to anything. So it's an interesting, piece of language. And I'm not sure, quite frankly, what it will do, if anything, without giving much more guidance in terms of what type of screening and formal, as you know, Dr. Carlson knows so well, there are formal history screenings and so forth and risk.
Yeah.
Anyway, I wanted to mention for number 4, acute pain as a qualifying condition. It sounds very simple. It turns out this is extraordinarily complicated if you consider inpatient therapy where acute pain is a high priority of treatment. Perioperative pain, trauma, and other medical conditions where severe acute pain is part and parcel of inpatient care. Consider all the rules regarding drug management in hospitals and who's gonna, and those that pertain to people bringing in their own medications and where those medications are stored, how they're delivered, how they're entered into MARs, the myriad issues, dosing, drug interactions, and appropriate education of clinicians around that, integration with, and maybe Misty can talk about that, with pharmacy services. It becomes very complicated. A very simple statement, 7 words that have huge import. And I'm not sure how in the world this is going to be operationalized. When you think about things like vaping in an inpatient setting and all that kind of stuff. So I don't think we need to deliberate on this much further. I just wanted to mention for those who don't practice in that kind of setting or haven't thought about it, this is going to be an interesting, this is going to be a bear when it really comes down to it. I don't think, from what I know, there was almost nothing around discussion or information or seeking of information or advice and from the legislators who put this forward. It just seemed like a good idea, largely promulgated, I think, by advocacy groups, and I understand that, but it has tremendous implications in terms of practice of medicine. But with that, I would suggest, because it's now likely going to be signed and will be put into law, that we reorder our priorities with regards to our reviews going forward. And this is just by way of a note, Melanie, for the minutes, so that we can remember to do this, that we have not reviewed acute pain in detail. It was part of the larger chronic pain review. There was a little bit of a commentary in that that did address acute pain, noting that, if I recall incorrectly, that there really there's a dearth of any methodologically sound studies that demonstrate efficacy versus risks in that area. So I think it really is begging an evaluation based upon our charge to review the literature and look at efficacy, risks, et cetera. So I would like to put this one on the top of our list. Does any comments with regards to my thoughts about that from the board?
I fully agree with that. I mean, that's really where my questions were going. That language consideration is, sorry, I agree with what you said about number 9. I agree also with what you said about acute pain.
So I'm hearing no dissent about that. We'll just move forward, and Melanie and Sarah Ponce will sort of move that one up to the head of the queue when we are ready to throw somebody into the library again.
I actually have a question. I don't know if we're leaving this slide altogether, but before we do, I have a question about number 10.
Oh, yeah.
Yeah.
Not yet. You'll please follow me then. This is, I think this is going to dominate much of our agenda today. It sounds like, because there's a lot. I mean, as I said, there was just a lot going on.
Yeah.
I'll comment about number 11 real quickly without too many editorial comments, because it certainly pertains to the Pain Management Center at the University of Utah, which is the only accredited pain fellowship training program. But there are fellowship training programs throughout the School of Medicine that deal with pain, with neurology, rheumatology, PM&R, acute pain service in the hospitals and in the Huntsman Cancer Institute. This pervades the entire School of Medicine space. It has tremendous implications in terms of a legislative mandate that directly intercedes with ACGME, the American Accreditation of Graduate Medical Education, that regulates all postgraduate education and has to pass off on the educational offerings and so forth. So this is, again, a very complicated issue. I think the university will be probably very engaged. There's already a lot of engagement at various levels about this, but it sounds so simple, but requires a lot more thought and depth of consideration. Katie, please, Dr. Carlson, you had some comments as well.
Again, on number 10, so interrupt me if we're not ready to
No,
move on.
go ahead.
Curious to hear a little more about that. I mean, can cannabis be delivered to a hospital where a patient has been admitted for medical management of withdrawal from heroin or alcohol? I mean, is that allowed? Does a medical facility include an outpatient opioid treatment program?
No.
No. So what does that mean exactly?
I need to track that down in the law, right? I can define that for you. It's acute. Just a second here. Because I'm presenting, it's a little complicated. Can someone look that up in the law, Sarah Ponce or somebody else, really quick? I know it's in the.
Sarah Ponce, you got that?
Oh wait, this is just a second here.
Katie, I'll sort of pipe in while you're looking at it.
I got it here.
A resident is a place where you live. It's not a facility where you're in. It's not an acute care facility where you are in an inpatient versus a residential care facility. I think
so.
Go ahead,
this is how it's defined in the law. It's an assisted living facility, a nursing care facility, or a general acute hospital. That's it.
Okay, but a general acute hospital, not to kind of get overly specific, but a general acute hospital is where patients begin their recovery sometimes for medical management of withdrawal from alcohol, opioids, benzodiazepines. So
yeah,
I'm just trying to see how the teams in the facility would manage that.
Yeah, so there's still federal law, of course, in place that still prohibits medical cannabis. It's against the law under federal law, of course. So those facilities will navigate that. We're not their legal counsel. We just know what the state law is, and we know it conflicts with federal law. And we know these facilities, a lot of them rely on federal grants. And those federal grants require that they only provide certain types of services, and they may require that they only allow certain types of substances in their facilities, correct?
Correct.
So,
I mean, it does clearly conflict with the Controlled Substances Act, which is federal law.
Okay, but we also know that there are some privately run facilities. There's quite a few, right? So in those cases, they don't have as many federal restrictions. I'm not the legal expert on this, but the bottom line is that they're just clarifying here that, hey, it's possible to deliver assisted living facility, nursing care facility, general acute hospital, state law, allows it. But it could be that there are other competing, conflicting federal laws that don't allow it. Yeah.
And
Basically,
really my concern would be that, you know, on the clinical side, it just kind of sets the climate that utilizing cannabis while you're, you know, addressing an addiction, whether it's at the acute hospital level or elsewhere is acceptable, and that, you know, can lead to some problems.
Right. Right. So it is a very difficult path to navigate, Katie, to say the least, right? It is complicated because of what federal law is today. Yeah. Okay. Great. Let's move on to SB 190. I've got some friends from Department of Agriculture and Food here in the meeting, and they're welcome to join in if they feel the need to expand on any questions that come up, but I'll just go through a few things. So first item is there is a limit on the amount of THC that can be in a hemp product compared to the total cannabinoid content of that particular product. So we all know the 0.3% of the total dry weight, that's a standard, but also there is the standard that of all the cannabinoids, or the cannabinoid profile, within that profile of total cannabinoids, THC or an analog of THC cannot be more than 10% of that total cannabinoid content. So that is new. That's what's added here. So there were some concerns about hemp retailers selling products that had, while they met the federal law, they didn't. There was some concerns about the fact that the percentage of THC was very, very high compared to the other cannabinoids in the same dose. So, okay. Also, THC analog was defined, so that is clarified to expand to all of the different analogs of THC, not just Delta 9. So there's Delta 8, there's very creatively, these companies have created many different derivatives of THC that are now covered under the law very clearly, limited to the medical cannabis program and not in the hemp program. Okay. Marketing restrictions on a hemp retailer, they are required to, in their marketing, have an indication that they are indeed selling hemp and not cannabis or medical cannabis. It gets confusing because, especially in vape cartridges, it's hard to tell the difference. And so with the marketing, the hemp retailers now have a requirement that they have an indication that they're selling hemp and not these other products. So Research University may operate as an independent testing laboratory. That was critical, I know, to the Department of Agriculture to allow that. So we could see some universities step up to do some of the testing of the products in Utah with that law change. Also, performance standards for testing labs, cultivators, processors, and pharmacies. We are able to set performance standards that if they do not meet, they would not be able to renew their license. Their license renewal would be denied if they meet minimum performance standards. Or if when they go through an ownership change, if the new owners are unable to demonstrate that they can meet the minimum performance standards for that license with that new ownership, they wouldn't be able to make that ownership change with a license. Also, restrictions on cannabis cultivator accepting of industrial hemp waste. So in the past, that was feasible under certain conditions, and this makes it very clear that it's not acceptable. Sugar coating on gummies, this is just clarifying that that is legal. And the labeling, there's a lot of provisions that relate to that. Processor labels must have cannabinoid content, and identification of each derivative or synthetic cannabinoid. And I think this was more of a clarification regarding the cannabinoid content standard. There was still a requirement that cannabinoid content show up, but this was just a clarification that indeed every cannabinoid must be identified on the label. And then derivative of, or synthetic, it must actually state that it is a derivative or synthetic. It can't just say delta 8, it needs to say synthetic. So the patient can be able to tell, oh, okay, this is a synthetic or a derivative, not a natural. Okay, and then also Department of Ag is to set some standards regarding containers and labels that appeal to kids, and we'll be working with them on that as they write those rules. Beginning December 1st, 2022, liquid suspensions cannot exceed 30 milliliters. As you may know, there in the medical cannabis program, there were some beverage looking and they were sold as a beverage. And so the legislature and we supported them in this, decided to not allow that, but that does not come into effect until December 1st, 2022. Aerosol products were added as a medicinal dosage form. So that's like an inhaler or a nebulizer that, you know, requires a certain dose be released. People with seizures, I've heard it's something that they use. Anyway, so that is allowed. We'll see if manufacturers in Utah actually move on that because it is expensive to manufacture those type of products. But we'll see how quickly those type of products surface. But I think there is a market for them, although it may be small. Pharmacy agents may access the EVS. The electronic verification system is what the EVS stands for. That's where the recommendations appear when a provider, a QMP, makes a recommendation for an individual to receive a medical cannabis card. That recommendation appears in this EVS system. And also any treatment or medication history that the QMP feels should be known by the pharmacist at the pharmacy or by other providers in the future that may treat the same patient with medical cannabis. All that information is stored in the EVS. And there's, of course, security standards for the EVS. Initially, when we launched the program, we did not have a role for the pharmacy agents to access that. But the legislature felt like that policy should change. And so they've required we change that policy with this change in the law. But in conjunction with this change is a requirement that each pharmacy agent complete privacy training. And that was a good move. Obviously, a lot of these individuals that are working as pharmacy agents, they don't have the training and background that a pharmacy technician would that works in a Walgreens. They don't, and they aren't required to go through that extensive of coursework. What they are required to do is now go through this privacy training because they're gaining new access to information that is confidential and medical private information. So that's item 11. That'll take some time to develop that access. That's why we've got an asterisk there, but that'll be allowed. And then also item 12, terminally ill card is good for 1 year, and terminally ill caregivers, they're eligible for a conditional caregiver card. So in a terminally ill situation, these are people that are expected to live for only an additional 6 months at maximum. Some live beyond that, but that's at least what's expected. And so it's an end of life situation. And in some cases, we were finding that individuals that were seeking medical cannabis cards in those type of cases, that they were bedridden and they needed a caregiver to go buy the medication for them at the medical cannabis pharmacy. But that caregiver had to pass a background check in order to become a caregiver. This allows them to be eligible for a 60-day period that a caregiver could go and purchase and receive a caregiver card for only 60 days if they haven't passed the background check. But they would be, if they want to have a caregiver card beyond those 60 days, they would have to pass a background check. And then in the past, terminally ill cards did not expire, but that's been sharpened up to be for only 1 year now. Okay, so that's SB 190. That was Senator Vickers' bill with us. Representative Ferry was the floor sponsor. Are there any questions about that? Or any of the 12 provisions I chose to focus on?
I do have questions. I have a question about number 11.
Yeah.
I just need, I guess I need some education on what that means. At first I read that and I thought, I interpreted pharmacy agents as anyone who's in the pharmacy, you know, a pharmacist, a technician, et cetera. In a commercial pharmacy, you know, just like they check the CSD. I
Yep.
thought that was granting them all access to the EVS. But that's, yeah, are pharmacy agents, is that a special term used for pharmacists that work in a dispensary?
No, so there's pharmacy medical providers. Those are pharmacists licensed by DOPL. And then completely separate from that are entry-level pharmacy agents that perform a responsibility similar to a pharmacy technician. And in the past, pharmacy agents in a medical cannabis pharmacy have not had access to the EVS, and they still don't. But this law requires that we modify our software to create a role for them to be able to access and provide administrative support to the pharmacist, as the pharmacist leads the operation there at a given moment, just like a pharmacist does at a Walgreens. That pharmacist continues to be the supervising professional licensed by DOPL that would, you know, all things happen under their responsibility and license.
Okay. So kind of like
yeah.
like a proxy in a medical clinic. They can, physicians can identify a proxy to check the CSD.
Right, right. So yeah, and also keep in mind that no pharmacy agent will get access to the EVS unless they're given permission by the pharmacist in charge at the pharmacy.
And this is, okay. And just curiosity, do pharmacy agents now have that ability with the CSD?
No. Pharmacists do at a regular Walgreens,
but
you know,
not
of course,
agent.
but
Okay.
yeah, pharmacy agents do not, absolutely not at a medical cannabis pharmacy. It's only the pharmacist that would have access there. Yeah. Okay, good questions. Any other questions from the board?
I have one question regarding the same number 11. So if we're going to communicate better with the pharmacist, this is sort of a little bit off from that particular statement, but communicate better with the pharmacist about the patient's medical history, their previous drugs, medications that have been tried or failed. And we're going to put more information in from a QMP standpoint. Does that require, or should it require, any further specific patient consent, that they're aware that we're communicating with the pharmacy at the marijuana dispensary?
So when an individual receives a medical cannabis card, they are informed of the fact that their information is going to be put into this EVS, electronic verification system. And so they aren't able to join the program unless they allow this to happen, because there's a need for registration, electronic verification. It's used for those purposes, right?
That's demographics, right?
Yeah, but also we don't mail out medical cannabis cards, physical cards. It's always digital. We mail them, email them their a PDF version of their card with a barcode, and that's what's used in combination with someone's government issued ID at the pharmacy to prove that they are who they say they are, and that they are indeed someone that has a card that's been issued in the electronic verification system in the EVS. And someone's card could expire at any moment because they have different expiration dates. And so a pharmacist and a pharmacy agent would need to verify as someone comes whether they have an active card or not, even if the patient presents a physical paper printed out card that they were emailed. So there's that information that they can, are informed about when they receive a card. And then the pharmacies themselves, if they are using this data for any purpose, then they need to have the patient consent in documented, either electronically or physically, that they are allowing the pharmacy to store their information, to use their information for purposes A, B, and C, like a regular medical clinic would need to, right? That needs to be documented. And so as we inspect these pharmacies, we would confirm that indeed those consents have been given. For example, if we see that, I guess one complaint we got is that a patient was being sent information about an event, an educational event, I think, at a medical cannabis pharmacy. And they thought, well, why am I receiving these? I don't remember ever giving consent to the pharmacy to send me these via text. Okay. And so we went and investigated. We found out that indeed there was some fine print, but it was there where they did indeed give consent for that particular pharmacy to reach out to them regarding certain purposes. So there's those type of consents that we confirm are in place. These facilities are required to be HIPAA compliant. And so we check for those indications within their processes. Any other questions? Did that address your question, Jennifer?
Sort of. I mean, all of that contact information and email information, it's not really medical history information.
Yeah.
So, I mean, I think for the patients to get better, there needs to be more communication between the QMP and the pharmacist about what's worked, what hasn't worked, what to try next. But that's medical information. That's not contact information. And so
right.
I don't know.
Yeah, medical information a lot of medical information is stored in the EVS, and its purpose is to ensure that there's a continuity of care between the QMP and the pharmacist that are helping that patient identify the products that are the best, the dosage forms that treat their condition the most, the contraindications that may be in place between certain drugs they're taking outside of the medical cannabis program and inside of it. And different medical providers provide different degrees of information. Some don't provide anything, and others choose to provide more, and that's their option. So they can choose to provide a lot of information, and they can choose to provide only so much. But we would emphasize we would only want providers to provide something if it's relevant. Otherwise, don't put it in. We don't want them to err on the side of just throwing a bunch of private information, but they would need to confirm they're doing that with consent from their patient. So their patient knows what's happening as their information is exchanged and shared. Any other questions about SB 190? And Dr. Fine, do you feel it's appropriate to ask if representatives from Department of Agriculture and Food have anything to share?
Sure.
about this bill. This is a bill that typically for the most part impacted them.
Yeah, and this was a bill that sustained a lot of discussion and hearing and contentiousness, and also I think our friends from agriculture would be happy to weigh in, and Dr. Forsyth, toxicology and others would be welcome if they would like to make some comments.
I'd be happy to make some comments. This is Dr. Brandon Forsyth, the director of the Medical Cannabis Program for the Utah Department of Agriculture and Food. Yeah, a lot of this bill was focused on isolating what are commonly viewed as psychoactive cannabinoids to the medical cannabis program here in Utah, where there's increased scrutiny on the products, so they're tested more rigorously, and also where the patients are able to, or the consumer is able to talk with, or required to talk with the QMP prior to using it. There are a lot of people that are opting to self-medicate with some of these products that you're able to find just at your corner store that are Delta 8, HHC, THCP, just really unknown cannabinoids with unknown toxicology specifically that we're concerned with. And so isolating it to the medical cannabis program really is our intent with a lot of this. And kind of along with that, I know it's been a focus of the Cannabinoid Product Board to start looking at making more medically minded products available. And that's certainly part of our goal with this as well, you know, getting the medical cannabis producers to start making some of these products that consumers clearly do want access to, but that we feel are more appropriately housed within the medical cannabis program.
Thanks, Dr. Forsyth. Any questions for Dr. Forsyth from the board? It's a good opportunity. I'm not sure if you all have met him. Extraordinarily gifted guy with, don't mean to embarrass you, Brandon, but a tremendous resource. We're in Utah. We're really lucky to have someone of Dr. Forsyth's quality and interests working in parallel here.
Thank you.
Great. Thanks. Okay, let's go on to SB 153, medical cannabis governance structure. So the Legislative Management Committee will create a working group comprised of legislators to study and to make recommendations regarding a single state entity to oversee all medical cannabis regulation. The Utah Department of Health and the Utah Department of Agriculture and Food ought to report to the working group as requested. And the working group will work with the industry, patients, medical providers, and others to conduct a review of the state's governance structure over medical cannabis. We'll study the various regulatory structures throughout the nation regarding state agency regulation of medical cannabis, and at or before the October 2022 interim meetings, this group of legislators, this work group, will make recommendations to the interim committees of health and agriculture on whether the committee should recommend committee legislation to unify the regulatory authority over medical cannabis under a single state entity. So we'll be providing a lot of information, I would assume, to the Legislative Management Committee and to this working group as they put together a study. And we want to help them learn about these different management structures that are in place in other states. There's some states where it's under a Department of Commerce, where it's under a commission that's directly under the governor. There's under the Department of Health and Human Services, there's under the Department of Agriculture, a lot of different models out there. In adult use states, we see some coordination with their versions of the DABC because it's adult use like alcohol. But I wouldn't expect that to be a model for Utah, just because we do have different purposes of our program with it being medical only. So are there any questions about that?
Just a comment by me. You know, this sort of has been kind of a long time coming, because it's been a bit of a not a free for all from the standpoint of total chaos, but when you have a lot of different heads on the entity, it's hard to coordinate and to create cogent policy. There's also a strong interest in sort of integrating, or I'd say maybe having science lead policy rather than the other way around, which has sort of been the way it's been, where policy has always been sort of out front of the science and evidence and practice of medicine per se. And so I won't mention particular legislators' names because I don't want to misquote them, but there's certainly an interest on Health and Human Services Committee by some. Some are resistant to that. Others really feel that the science is not settled and it's important that the science and evidence drive the program and it's well integrated. And so it's a work in progress. And Rich, I know that, you know, through discussions that I've had with Rich and the Center for Medical Cannabis, this is an evolving process, and some people feel we're behind the curve. Other people feel like we're way ahead of ourselves. We're really trying to move towards a coherent and cohesive model, and so that the legislature doesn't become, the legislative session doesn't become just sort of a water balloon fight every year for whose interests and special interests, perhaps, or advocacy interests, or you know, woe is me interests may dominate, and then you have to live with it for a long time. So it's an opportunity to work in between legislative sessions to really create some of this coherency before we actually get to the next session next year. So I think it's a really good next step. I think this signals responsiveness to some of the issues and how our soon to be called Cannabis Research Review Board fits into this. I suspect it will fit in dynamically so that there will be much more attention to actually what we are doing and going forward, what the purpose of this was intended to be, which is to truly advise and be a sort of a scientific advisory board and not simply a decoration sort of sitting along the side. It's not an academic endeavor we're into, where it's a very pragmatic one. So I'm hopeful.
Yeah, I feel the duties of the Cannabinoid Product Board are, one of those is to ensure that our program continues to be medical and even puts little tweaks on those things that help it even narrow that focus even more. And so I agree with you, Perry. I think it's a cornerstone of a medical cannabis program to have a board like ours that is based upon some of those studies, that makes recommendations based on the evidence out there of scientific rigor. So wonderful. Okay. So also, just as a there was SB 46, that was the medical cannabis patient protection. I won't go into too much detail here, but this bill just amended protections for medical cannabis patients, including public employees, to protect holding of a medical cannabis card and medical cannabis recommendations. It made some clarifications that law enforcement needed in order to, I think, comply with the intent of the law. So there's that. And then House Bill 2. This is called the new.
Can we just go back to that, Rich? Sorry.
Go ahead.
Number 40. I'm just a little more background on that. I'm guessing this is coming from cannabis card holders who are being prevented from using cannabis while at work.
Yes, there was a few cases where there were public employees, like a firefighter or law enforcement, that were unable to keep their medical cannabis card because of the fact that they were in law enforcement. And there's certain certifications, like a peace officer certification, post certification, that requires compliance with federal laws. And there is a conflict there because of the fact that federal law still prohibits
Rich, I just want to clarify, Katie, this does not allow them to use it at work. It allows them to have a card, and they still have the same occupational standards
Thank you.
for things. So yeah, so
Right.
Rich, just to make sure to really answer her question, this is about card holding. So there was a place that said, hey, you can't be employed if you have a card, even if you're using it very episodically. So they retain the standard of OSHA, et cetera, in these workplaces.
Yeah.
So we're not changing that. It's just that you can't be discriminated against for just having a card.
Right.
Okay.
Yep, thanks
yeah,
for
just
that,
to clarify. Yep.
Dr. Woolsey. And there is some specific language, I think was actually in SB 190 that also addressed this general issue. And it made it really clear that if they had a post certification, that they would not be using during their shift, and that they would not be impaired. Obviously, that goes without saying, but yeah. So great. Okay, so House Bill 2, that's the new fiscal year Supplemental Appropriations Act. And this appropriated $538,000 from the general fund to fund research on medical cannabis use and chronic pain. So as many of you know, Representative Ray Ward proposed this appropriation and it was approved. And so we'll be working internally to hammer out the details of what that process will look like. And we'll share that with the group when that is known. But yeah, so that was a positive thing. There was, I think, a question of whether that would move forward. And I think thanks to Dr. Representative Ray Ward and other legislators, they did give that approval.
And Dr. Fine did a good
Yes.
testified. Yep.
Okay, any comments about that appropriation?
I think, Rich, it's important. We'll be passing this through to an independent research organization. So this will be done independent of our program, as it will include some evaluation of our program, and we're excited to have an external review.
Thanks,
Great.
Sarah. I was wondering about that. Will we know who, will we be able to know who that group is?
Yes.
We'll do an RFP. We'll do an RFP, Katie, and it'll be, the standard process that a state agency undergoes. Yep.
And we as a board will be anxiously awaiting the outcomes of both the process and the intermediary end outcomes of that of the study and evaluation and assessments that they're doing. So yeah, this is something this is applause worthy. As this with COVID being the top line issue for the last couple of years, almost nothing could expect appropriation. And so this is, I would say this has come in the category of minor miracles, sort of not maybe up there with seagulls, but close, if you get the illusion. Thank you, Sarah, for nodding.
Great.
Okay.
So this is not part of legislation, but I just wanted to give the board a quick update about some medical cannabis administrative rules that we have in place that have been drafted by the Utah Department of Health. So there was R38402 that related to medical cannabis cards. There was some language that the legislature wanted us to draft that related to out-of-state cards. When a non-resident applies for a Utah card, and it's for 221-day calendar during each calendar year when they can get those out-of-state cards. So we set some standards there. And then there was also R38413. This was related to administrative penalties. We clarified what those penalties are for violations that a medical cannabis pharmacy may commit, or a medical cannabis courier, or a pharmacy agent. Anyway, so that is what that was all about. Those will become effective. Actually, it's expected later this week that those will become effective. And then we have R38406. This sets a lot of standards for medical cannabis pharmacies. There will be a public hearing held on March 28th later this month. And then assuming that all goes well when we have the public hearing, and as we put public comments, as long as there's no tweaks that need to happen, then those would be scheduled to become effective on approximately at the earliest April 21st. So that gives you an update. If you have detailed questions about the content of those, I'm happy to share those with you, but that just concludes my presentation. So there you go. Any questions beyond what have already come up?
Thanks so very much, Rich. We're going to, I suspect we were going to spend most of our time on this, and it was certainly worthwhile doing. So we'll sort of cleanse our palates. We've got 30 minutes by my clock before we get to our public comment section, which I want to make sure that we allow opportunity for folks to weigh in. So the next item on the agenda is sort of a where are we at with our plans to develop a listing of products that are existing by the location within the Utah Medical Cannabis Program, the different pharmacies, the products, what they consist of, the formulations, the dosages, proportions, all that. So Dr. Woolsey is sort of heading that up with her colleague Jesse, is Jesse on the line, or is that something you're going to take, Sarah?
Yeah, as well. I think Sarah's going to start us off though.
There's Jesse. I see. Thank you.
Yep. Thank you, guys. And let me just get sharing. So, Rich, thanks for that update. Lots happening in the cannabis program. It represents a ton of work from staff. Really good job. So on to what's on the agenda called formulary, but really we need to change that language. We heard last meeting that we need really more of a product list and assessment. So heretofore, we'll try to work on improving our referring to this as our product list. Reminder, we're interested in assessing the adequacy of our products to meet the needs of patients, communicate those to clinicians so they can recommend them, and then begin to look at a table of products for analysis for academic partners. So ideally sharing something that could be digested by people with other research questions or other questions. So that's kind of where we're heading with this idea. Just reminder, elements of the report that this is actually new. So we're looking at, these are the elements that you all might be interested in, and Jesse, I'll turn the time over to him in the next slide, has given us the draft of what, in working with Brandon Forsyth and his team and our electronic products list, what we can produce that will be of interest. And the idea that we're looking at, are there high THC products? Dr. Fine continues to encourage us to be cognizant of where are there products that may not have medical purposes and could be harmful to the health of the public. Number two, what is out there that aligns with our recommendations? And then eventually, what is being purchased most commonly and what's being produced most commonly? So if we're working to move our product lines to meet needs of the medical program, are we seeing them both available but also bought by the patients that say they want them? And with that, I'm going to turn the time over to Jesse, and I will advance your slides, Jesse.
Forgot to unmute myself. Okay. Thanks, Dr. Woolsey. So just to start
Jesse,
with,
go ahead and introduce yourself, just for those who have not yet met you.
Yeah, my name is Jesse Hockley. I'm the data analyst for the Center for Medical Cannabis. Helped start to work on this product list and assessment here. Just to start with how we're collecting the data, it's pulled from our MJ Freeway database, where our processors, pharmacies, and also our labs hold all of our information. The current draft of the product list is based off of the mean cannabinoid percentages per product that processors sent to pharmacies. We've tried to go through to filter any invalid lab results or ones that may be inaccurate, both mostly through automatic processes, but I also do a manual review of certain products that seem to have high variances that seem strange after the automatic processing is done. And then we're also calculating the standard deviation per cannabinoid per product, so that you'll also be able to see not only the mean, say THC percentage of a product, but also the standard deviation across lab tests for any given cannabinoid for each product. Let's just hop to the next slide, Sarah. Oh, did you skip one? Okay, here we go. So currently there are some limitations with the product list that are kind of going to be inherent. The first is that just based off of how the database is structured, each organization is going to have slightly different names for each product. For the sake of simplicity, we decided to use the names that the processors use for each product, because those are fairly consistent. After a processor sends a product to multiple pharmacies, the actual product names on the shelves may be slightly different for patients. Usually they don't rename them very differently, but just for the sake of ease, we're using the names that the processors have for each product rather than say the display name on the shelf. I should also mention, the scientific benefits or basis for a lot of the health benefits of many cannabinoids are limited. We have the percentages of CBN and many others, and even, CBD and THC, there's still a lot more research to be done there. And then the use cases for many prescriptions are oftentimes, very patient specific. So we do have nice overlying, cannabinoid percentages per product, but there are certain things such as body weight and body surface area that, kind of have to just be handled at the individual per individual basis. And pharmacists also have access to all the dosages and cannabinoid profiles there. I will also mention, so the current draft version of the product list doesn't have sales data at the moment. There was a slight problem with the database that actually just got updated Friday. So that will be included in the next version. So I should also mention that the charts that you're about to see are since inception, or since July of 2020. So near inception, though we should also be including, say, a more recent version of the list of products, because the products available will be changing over time. Let's just pop into the next slide here and show a quick breakdown here. So since these are a count of the individual products per sort of THC to CBD ratio since July of 2020 that we've had. As you can see, it's pretty heavily weighted towards having no CBD whatsoever, or a greater than 20-to-1 ratio of THC to CBD. We do have some products available with 10-to-1, 5-to-1, 1-to-1 ratios. Pretty similar counts of them are available here, and a fairly low number of products that are available at having more CBD than THC. And let's just pop in the next slide, actually. Oh, I should also mention these charts were pulled on February 22nd. So this is updated as of a couple weeks ago here. Sorry, next slide. These are called violin plots. They're similar to box plots, but these ended up looking a bit better than the box plots for this case. So these basically just show the distribution of THC to CBD ratios per product category. So just to get into a little more detail here, infused edibles is a good example here. You can see that it's very wide at the bottom, so that most infused edibles have pretty low THC to CBD ratios. That's below below the 50 to 1 ratio there, but there's a just very long tail that goes up. Cartridges and pens, as you might expect, having higher THC concentrations. It still has more products kind of at the bottom, but you also have another, bump higher up there. So you do have a lot of products with that are cartridges and pens with high THC to CBD ratios, and concentrates, kind of similar bimodal looking distribution there, where you have a bunch of them kind of at the top and a bunch at the bottom. Though I should also add that there's very few concentrates that end up at the pharmacies. This is only like representing 20 or so products because most concentrates are used more in processing than being sold by the pharmacies. Let's just pop to the next slide here. Oh, sorry. This is, I put this on a different scale. You'll notice that the THC to CBD
I'm
ratio.
sorry, Jesse. I'm sorry to interrupt. Can you explain what I thought these were all products that are in the pharmacy. So I didn't follow what you meant when you said.
Most there are relatively few concentrates are being sold at pharmacies.
So where would you find them?
Most things being, most of the times concentrates are turned into cartridges or in pens or infused edibles before they reach pharmacies. So
So there's like a middle person. I mean, what?
So Jesse, just to clarify, Katie, this represents the concentrates that are sold, correct, Jesse?
Yeah.
So Katie, these are the concentrates that are sold. He's just saying there's not a high end of those compared to the infused edible and cartridge pen products.
Yeah. If someone from agriculture wants to pop on, I remember you did have a term for these kind of these sort of types of products. They're usually used in production more so than medication.
Can I jump in there, Jesse?
Yeah, go ahead.
So the concentrates are made from the flower. It's kind of like the raw output of a process. And we like to test at that step because it allows us to get better detection limits because they don't add in all those other weird stuff to the matrix C. So by testing there, we're able to get a more accurate look at like pesticide, heavy metal contamination. And so those products aren't ever actually used by the consumer. They're used farther along in the process to make the infused edibles or vape carts, whatever it happens to be.
Yeah, so it's possible that most of the things listed at the pharmacies as concentrates were just oils. So they probably might be more accurately listed as non-infused infused non-edibles rather than concentrates, but some sort of data issues there. Let's just pop at the next slide here.
Katie, did that clarify your question?
Oh, sorry. Yeah, next slide, Sarah. I think we're good here. And then, like I said, this is just on a different scale because infused non-edibles and flowers tend to have, on average, much lower THC to CBD ratio. So this is going from, 1 to 20 rather than 1 to several hundred like the other one. Infused edibles, I think Dr. Fine said this was less concerning. This is mostly just balms, oils, bath oils. These tend to have a little bit higher or less THC, more CBD. And then flowers, of course, being more natural products, they don't go through the processing and condensing process that other products would, so they tend to have a lower THC to CBD ratio. So let's just pop into comments and discussion here.
Thank you, Jesse. Any additional questions for Jesse? Really well done overview of some of the things I think we're interested in. Dr. Fine or others, do you have questions?
At this point, I think, we're just at the beginning of this, and Sarah, again, a real tribute to your leadership in helping get this initiative forward. It's going to help, I think, tremendously with our qualified medical providers and hopefully LMPs as well going forward to be able to match the product that they believe is in the best interest of their patient from having a card for, matching it with the recommendations that our board makes in terms of where there might be some therapeutic benefit versus mitigating harms and risks of a high dose exposure. As you can see right now, we are sort of inverse in terms of our recommendations and guidelines, and in terms of what we have recommended for most of those conditions where we have seen some evidence would suggest that starting with low dose THC and relatively higher dose or proportions of CBD and perhaps some of the other non-psychoactive cannabinoids are the more favorable balance. But sort of this implication here that high dose THC somehow equals medical, and there's absolutely no evidence whatsoever to support that conjecture. The only products, of course, that you're aware of that we know of that are, that are actually available in terms of the pharmaceutical side of the marketplace and FDA approved and all that is pure THC congeners for nausea, vomiting, and for HIV and cachexia and cancer, and that's a THC product, but it's a 5 milligram dose, so the ratio is infinite because there's no other cannabinoid but a THC or THC synthetic THC, but it's a relatively low dose compared to what's available out there on the pharmacies. So this is the effort to try and find the therapeutic sweet spot, I guess I should say. And without this process going forward, like we are doing now, we won't be able to get there. So thank you, Sarah, Jesse, for taking over. What I would like to do going forward, especially with Sarah's imminent departure and as Dr. Hoffman gets on board, and I'm not sure with all the things that are going to be on her plate, and you can speak to this, Dr. Hoffman, if you're online here, is how much you're going to have a lot on your plate. So I would like to actually invite one or two other of the current board members to sort of join me in meeting with Jesse sort of on a regular basis to help, keep this on a path, keep it up front in terms of line of sight, modify our objectives and goals as we start learning more, and to sort of shape the structure of this. So it really is a pragmatic tool and not a statistical or an academic one. Other people who want to use this for research purposes, great. I think our job is really to help inform the Center for Medical Cannabis and the legislature per our charter as to what's going to be most useful for patients, for providers, and mitigate risks to the greatest extent we can from what we know. So is there anybody who would like to, you don't have to say now, but we want to keep it a small group, A, because it's easier to get together, and B, we can't really be a quorum by rules. It's sort of a little sort of mini advisory group to work with Jesse, and I'd like to do that just because this is something that I have a fondness for, as Sarah could testify. But anybody who's interested, tell you what, just let me know, or I will reach out to you if I don't need. I will help you volunteer if I don't hear from you. Dr. Hoffman, I see you've there you are, bright and shiny. Welcome.
Thanks, Dr. Fine. I'm a little bit under the weather, so my voice is a little crackly and I may go into a coughing fit, but I appreciate that Sarah grabbed the bull by the horns and really got this off the ground, but do really recognize that the subject matter expertise rests with all of you, and I definitely would appreciate some collaboration in continuing to build this out and move this important work forward. As you said, the expertise of your group needs to inform our program. It needs to inform our legislature. It needs to inform our prescribers. And so I strongly support and advocate that continue to be work that is driven by all of you. So I want to be supportive and participate and contribute as I go through the very steep learning curve you alluded to earlier in this area. I'm still working on my QMP training right now, and this is a whole new ball of wax for me to get into at this stage. So appreciate that extra support and would love to have the participation of other board members working with our staff to continue to flesh this out. Thanks.
Thank you, Dr. Hoffman. We're going to sort of compress and accelerate here. Our next line of business is to turn the discussion over to Sarah Ponce. We're going to sort of to have a brief discussion on the board bylaws, something that's not particularly interesting, but it's a necessary sort of administrative step. Excuse me, the bylaws were adopted going on almost 5 years ago, 4.5 years ago now. And so it's timely to review them. there are two sections I particularly wanted to draw to your attention. One is under our mandate, which speaks first to risks, safety, and then efficacy. We spent most of our time over the last couple of years, since we've really gotten going, reviewing the conditions, looking at evidence for efficacy per se, or potential therapeutic benefit. We haven't really spent a lot of time on risks and safety, and I want to come back around to that at the end of this, but I wanted to sort of signal, I don't think we really need a change in this. It outlines it quite well, but I wanted to draw your attention to that. But then if we go to page 3, if you've pulled that up, and I don't know if Sarah, if you can put that on the screen, it's section 4, which is sort of a new addition to sort of come into compliance with how some other state agencies or boards or and so forth are conducting their business under the Public Meetings Act, but also to sort of refine things and things we've learned over the last few years about how to conduct our meetings and keep them moving and keep them constructive and positive and critical, but ever moving forward and in compliance with our charge. Some of this comes from the fact that we have not been able to meet for 2 years in person, and so a lot of our evolution is and learning curve is from doing virtual meetings, which I think we've gotten better at, but certainly has their own challenges. So with that said, I don't know if you've all been able to pull that up on your own computers. Sarah sent this out earlier, and Sarah, why don't you go ahead and just read through those changes and see if the board has any thoughts to add, to edit, to discuss before we adopt, take a vote on whether we should adopt some suggested changes or not.
Well, first, what I wanted to do was to just discuss that yes, these are several years old. So I wanted everybody to take the time and review those. And I sent everyone on the board a link to the document so that we could make comments on it, and then to have those comments back to me by March 8th, so that we could then vote on it in the next meeting. So we have time to actually review it each and thoughtfully discuss what changes we want. So that's what I was going to request during this meeting, so that we don't
Sarah,
take the time to go through it page by page.
Oh, no. Could you just go through the last section, the one that you highlighted, so that the board can really understand what
Sure. Pull that up.
Great, thanks. Only take a minute or two, but I think it's worth. I've got it here if you'd like me to do it, but oh, you got it there.
Can you all see it? Sorry, everything's being slow, just in time. So you wanted me to present page 3?
Yeah, just that section 4. I highlighted on that other section, just the line. You can see based on research, the board shall evaluate safety, risks, and efficacy. I'm going to come back to that in the last couple comments about what I want us to think about for the next meeting. But let's go ahead to page 3, section 4. There we go.
So this was taken from what they do in the Medicaid meetings to help us kind of evaluate public comment to ensure that it's related to the agenda for our meetings, and so that it's helpful for our discussion. Here, the notice of all meetings shall be posted on the public meeting notice website. Members of the general public may comment or give testimony with the following limitations. Each person must complete and submit a conflict of interest disclosure form, which we have also for you to review. And only one person from any organization may testify. Also, comments are limited to meeting agenda items, and unsolicited testimony will be limited to 2 minutes.
Okay. So consider this, send comments back to Sarah, and we'll go back and forth and have a discussion and then a vote at next meeting. That'll be on the agenda. So Dr. Cashin, I see your hand up. We're going to get to you, and that's first up when we get to the public comment section. which I think is, let's see, let me just pull up my agenda. What I wanted to do before we get to the public comment in the last couple minutes here is want to have the board also consider over the next week or two at the longest, so that we can get ourselves together. By ourselves, I mean Rich Oborn, Melanie, Sarah Ponce, myself, and Dr. Hoffman to go over the agenda setting for the next meeting. It would help for me as your chair to know what's currently you're thinking about now that you've heard all the stuff from the legislative session, where things are going, what concerns you may have, so we really can formulate an agenda that is pertinent to your issues. Sarah Woolsey did a great job culling information as well from everybody about where we sort of stand now on our 2-year anniversary of being a program and a board informing that program. So please do share your ideas. Go directly to Rich, myself, to Melanie, Sarah Ponce with your ideas, and then we'll shape those as an agenda going forward. One thing I think we do want to talk about next meeting. April is only 3 months away from July. It'll be a little less than 3 months from July, where we'll have a bit of a turnover in the board in terms of leadership and all. And so we want to talk about succession planning, I think, a bit, and organize ourselves around that. The other area I want to, I think is highly pertinent, and I now draw back to our charge with safety and risk being sort of front of the mind issues, that some of the discussions I had when I was interacting with legislators during legislative sessions about various aspects of things that were coming around and about had to do with safety. And now that we have 43,000 more or less, or 40,000+ Utahns with medical cards, and receiving, as you saw from Jesse's presentation, relatively high doses of unopposed THC. We don't know exactly what the dosing is, the dose schedule, formulation, all that in terms of pharmacokinetics, but I think we can infer, at least at this point, that we should be mindful about the effects of long-term exposure of high-dose THC, whether it's vaped, orally ingested, however it's formulated, on many tens of thousands of individuals. One area of attention came out when there was a Department of Transportation report that basically concluded that in 2021, fatal motor vehicle accidents, collisions of one sort or another, vehicle, pedestrian, etc., single car, had gone up. It's a phenomenal amount. It's about 30%. It's a huge leap. And one of the questions arose is, since there is impaired drivers, have traditionally been viewed as alcohol impaired or cognitively impaired, or maybe other psychoactive drug impaired, cannabis is a frequent found drug in people who are impaired and involved in motor vehicle accidents. And so the question arises, to what extent has the medical cannabis program contributed to safety issues, at least on our highways? And what constitutes an intoxicating or a cognitively impairing dose commensurate with alcohol, and so forth? So I think it would be very useful for us to, as a board, to be informed by the Department of Public Safety about that. And so I was sort of looking at who might be the best person to do it, and there is a division of highway safety. And 1 second. The head of that division is someone named Carrie Silcox, who I've not met. I don't know if anybody here has met Ms. Silcox, but I would suggest that we invite a presentation about what are known risks, how does the Department of Transportation data conform with safety issues? I know that there's a very avid Mothers Against Drunk Driving Utah division and part of it. Sometimes MADD stands for Mothers Against Drunk Driving. It's also drugged driving. We may want to get a perspective from that advocacy group on the other side of the coin, just again to sort of shape our thinking and inform us, so then we can then perhaps in our researches go into safety and risk mitigation issues with those sorts of things in mind. There's the other components of this, such as substance use liability and risk, addiction liability and risk for, it's a large proportion of individuals or a fairly large population being chronically exposed. I don't think we really know much about that in Utah. There's NIDA and SAMHSA data, and maybe in the not too distant future, Dr. Carlson or someone with that kind of experience and expertise might want to weigh in or help us find somebody who can help round out our researches and our work commensurate with our charge. So that's sort of what I'm thinking. So we'll talk about that maybe at our planning meeting for next time, but I wanted to let you know at least that that's sort of front of mind as I sort of reviewed our bylaws and what our charge is and how to go forward in a very constructive way. Again, completely in alignment with our duties. Any discussion about that before we turn over for public comment? Okay, we will open the floor to public comment. Dr. Cashin, please introduce yourself, your affiliation, any disclosures, and have at it.
Great, thank you. Well, my affiliation is as an educator. As disclosures, I have no conflicts of interest. I don't sell or promote any product for any financial compensation. So I'm not really tied to any organization other than the university and college. I did have I have a lot of thoughts, but to keep this short, I have two questions. The slides that Jesse showed, are those going to be made available? As one who researches and educates on cannabis every semester, that information would be really helpful to me. So will that be made available publicly, the slides themselves, besides the recording?
Yes, they will be posted on the public notice website.
Great, thank you. And then the second thing is I'm really grateful that this board focuses on safety and efficacy. This is something that I teach all the time, and in fact, I'm just finishing up my current cannabis class. And I'm glad to see that the semi-synthetics and synthetics derivatives will be removed from the over-the-counter market. But I think with the new percentages, if the governor signs SB 190 into law, we'll see higher THC products in the over-the-counter market. And I don't know if anyone from the ag department is here or could speak for them, but since hemp products tend to be an unregulated market, will there be any oversight in terms of the cleanliness and purity of those products? Do we know?
I don't know that
Forsyth.
this is the appropriate forum for that. I'm happy to talk with you elsewhere.
Yeah, just connect me on email then. I just wanted to make sure that there's some oversight on that.
Okay, Russ, one more question, about 30 more seconds, and we'll turn it over to Dr. Viner.
Oh, no, I'm done. That's it. Thank you very much for your time.
No, thank you for those questions. Really appreciate your focus on that.
Yeah.
Dr. Viner, you're up.
Okay. Regarding the safety, as the THC levels go up, we got to take a look at things more severe immunosuppression as a side effect, psychiatric side effects, bleeding is often common. And so there are, and that's one thing with and then the THCV level goes up with the higher dose THC. So I think that really needs to be included on the lab results, the THCV levels, because of the high dose THC that's being used. And then for non-cannabinoid,
Dr. Viner,
Mark,
spell out for us what you're, the acronyms are great, but spell out exactly what you're talking about so that for the notes, so that Melanie can get it. THC, obviously we know what that is, but
the THCV goes, there's goes up as the THC goes up, the THCV levels will go up. And there's a wide variation in the THCVs, and that can cause additional side effects for medical, like for, if you're treating diabetes, you gotta adjust the diabetes meds. So I'm just, concerned about the high dose THC also. And then the side effects, bleeding, immunosuppression, mental
Got it.
health, anxiety, psychosis. And then finally, I was hoping, will there be more information for safety and quality control and to prevent harm to exposure to bad products with contaminants like microbial and fungal and mycotoxins, and putting on that there's no synthetic cannabinoid adulterants, and also pesticides? We never get info
Okay,
on
Mark, I think we got
pesticides.
Mark, I think we got the gist. I want Rich to have
All right,
Rich and
thanks.
Misty. Misty, why don't you comment first, if you would, as a board member?
Just for clarity, Delta 9 THCV is delta-hydrocannabivarin. It is an important metabolite, and I agree with Mark Viner that that would be useful information. The other thing I was just wanted to comment was the question that was proposed earlier by Russ and Brandon. I would actually also like to, if you guys could link me in on that conversation, I'd be interested in hearing Brandon's thoughts on some of the new policies. I think that would be a worthwhile discussion.
Absolutely. I was going to reach out to you soon anyway. So
Thank you.
Good. Rich, do you want to comment? And maybe Brandon, while you're on, talk about adulterants and microbials and other impurities, how we're dealing with that.
yeah, I'd be happy to address that. We actually already do test for THCV. It's actually a unique cannabinoid, not an analog or not a metabolite of delta 9 THC. It has a different number of carbons in the little chain there on the tail. We do quantify that already. It is on our COAs from our laboratory, and also on the COAs from the other independent testing laboratory. And we do quantify total yeast and mold, total aerobic bacterial count at this time. And we're about to hopefully be able to start getting tips again to do total pathogen testing as well. Not total, just pathogen testing of those pathogens of most concerns, depending on the product type. So we are actively looking at all those things. There's some confusion about what's actually being tested for out there, because some of these tests are taking place on the starting materials, because it's a better place to find those pesticides, heavy metals, before it actually gets put into the product. So those things are being tested. It's just not being tested in the final product.
Thank you very much, Dr. Forsyth. Any other questions? Right, before we sign off, I would like everybody to make an effort, find at the bottom of your screen, there's the reaction button. I'd like everybody to go to the reaction button and then do two things. Go to the applause and celebration. The celebration is a welcome to Dr. Hoffman, and the applause is for Dr. Woolsey. So thank you. It's been a joy, and thanks everybody for making the effort here. It's the one bad thing about these virtual meetings, you can't hear the wild standing ovation that you would otherwise get, Sarah and Dr. Hoffman, for coming on. So I can see by my clock, we signed in at 0900. We're signing out at 10:54. I always like to be a bit early, so thank you for allowing me to keep up with that tradition. We will see you next month. Please look out for emails from Melanie with regards to the bylaws issues and back and forth with her with comments. And then with we'll plan on an agenda meeting about 3 weeks from now, a week from prior to our next meeting, to put that together, send ideas, And then anybody who would like to join me before I lasso you with my Wild West skills, to join me with the list, the product list project. So stay well. Thanks all, and see you in a month.